In this video, I'm going to discuss the organism Streptococcus pyogenes. Streptococcus pyogenes is one of the most important pathogens, as it is a common cause of infection and it can cause rapid, dangerous disease if left untreated. S. pyogenes causes infections of the skin and mucosal membranes. Additionally, there are post-infectious sequelae that can even cause lifelong chronic disease. One way to remember one of the diseases that this group causes is to say, ah, that's right, because this organism is the organism that causes the strep throat you remember from your childhood. Okay, so there are basically 6 diseases caused by group A strep. The first one is one we all probably remember all too well, pharyngitis or strep throat. Pharyngitis, for the most part, is fairly harmless, but it can lead to scarlet fever if it has the right SPEs. It can also lead to some post-infectious sequelae, notably rheumatic fever, which occurs when the heart is damaged, or it can lead to acute post-streptococcal glomerulonephritis, and we'll talk about both of those. The next 3 are basically different forms of skin infections, impetigo, erysipelas, and cellulitis. 5 and 6 are our most severe forms of disease caused by group A strep, and they are necrotizing fasciitis, i.e. the flesh-eating bacteria, and streptococcal toxic shock syndrome. And if you've already studied staphylococci and learned a little bit about toxic shock syndrome, you know that this one is no walk in the park. So let's start with pharyngitis. So pharyngitis is pretty simple. Most of us have probably experienced it before. You get fever, lymphadenopathy, as is evidenced here by this very swollen lymph node. You get some tonsillar exudates. Often you have a bright red throat, so think back to when you were a kid and you either wanted to stay home from school because you were sick or because you just didn't want to go, which I'm sure you guys never did because you were all wonderful students. But I, on occasion, would try to fool my ICU charge nurse mother and tell her I was sick. And the first thing she would do is tell me to open up and say, ah, and she would shine a flashlight and look for bright red throat. For the most part, pharyngitis is pretty easily diagnosed. It can be done in any practitioner's office with a rapid strep test, which is literally just a swab of the throat, and then you perform an immunoassay just kind of looking for the streptococcal antigen. Now, Streptococcus pyogenes is the most important cause of pharyngitis, but it's actually not the most common cause of sore throat. Because these symptoms, fever, lymphadenopathy, even the tonsillar exudates, are not uncommon to other causes. In fact, many viral infections can cause these exact same symptoms. So you can't just look in somebody's throat and go, I bet you that's strep throat. But the other thing to keep in mind about strep throat is that while many of us associate it as like a childhood disease, remember earlier when I was talking about like the basic structure of strep, and I said that there were those M proteins that we make responses to, and that there are actually 63 different types of M proteins, and M proteins are immunogenic. Well, technically that means we could get strep throat 63 different times and feel just as badly every time. And so that's why this isn't just a childhood infection. It can also be an adult infection. In fact, this picture here is actually of my husband's throat on Father's Day 2 years ago. Normally we host my dad for Father's Day. And he woke up that morning and said, "Hun, I think you better call your dad and tell him not to come. I think I'm getting sick." And my dad's over 60, so this could be nerve-wracking to me. I thought maybe he's got to be crazy. So I said, "Open up, say ah," and then I saw this. And so being a very concerned wife, the first thing I did was grab my phone and take a picture so that I could share it with all of you. And the second thing I did was say, all right, go to the urgent care and see what they say. And when he got there, they did a strep test, and just like that, it popped positive. We can't always be certain of those though, because strep tests are only about 75% accurate. So what do you do if you get a negative strep test, but you're pretty sure it's strep? Well, you're going to send it out for either culture or PCR. Because here's the thing about strep throat. You can't really miss strep throat. You're not allowed to miss a strep throat diagnosis. So we're going to culture all negative tests. Because if you're wrong and you didn't put the patient on antibiotics, it's possible that they'll suffer severe post-infectious sequelae, some of which can affect them for the rest of their lives. But for most patients, you see this, you get a positive strep test, you put them on antibiotics, and they're just fine. Okay, so here's another thing that can happen with strep throat. Remember when we were talking about the toxins and I mentioned there were those SPEs? So one of those SPEs leads to a particularly nasty form of pharyngitis that also causes a rash across the body, and that's known as scarlet fever. So what's going to happen here is that it occurs in strains that produce this SPE, and within 1 to 2 days of the initial pharyngitis symptoms, you're also going to get this diffuse erythematous rash. It's going to appear initially on the upper chest before extending out to the extremities. The area around the mouth, the palms of the hands, the soles of the feet are normally spared, but the rest of the body, you're going to see this rash. You're also going to get this thing called strawberry tongue. So what happens first is it gets coated in kind of this white coating on the tongue that's going to peel off and give you this bright red strawberry tongue. Should the patient survive, because scarlet fever is deadly, the rash will disappear over the course of 5 to 7 days and otherwise be fine. There won't be any scarring or anything. But you can't miss this one either because it could be deadly. We don't see scarlet fever all that often anymore, but there was a period of time where scarlet fever was a big problem. In fact, in the 1700s, scarlet fever was running rampant in the big cities of the world. And one place that was having a particularly bad year for scarlet fever was Philadelphia. Can you guess where I'm going with this? What was happening in Philadelphia in 1776? And if you haven't listened to Hamilton or you don't know American history, which it's possible you might not, then you might not know that the Congressional Congress was meeting to basically write the Declaration of Independence. And they were trying to do this in early spring. So had scarlet fever not been running rampant, we would have had a Declaration of Independence a bit earlier. But what they figured out is that people were getting sick and it didn't seem like a really great time to congregate. So they decided to push it back a couple of months until this epidemic ended. So if that hadn't happened, we would have been celebrating July 4th on like April 3rd, except we wouldn't have called it July 4th, we would have called it April 3rd. And instead of having barbecues in Chicago, we might have been shoveling snow. But so we kind of have scarlet fever to thank for not shoveling snow. Anyway, we don't see it that much anymore, but it was a big problem and it is still deadly. So you got to keep an eye out for it. Okay, so let's move on to the next disease caused by group A strep, impetigo. This can also be known as pyoderma. That's another word that some people sometimes use to describe impetigo. Basically, this is a skin infection, and it's caused by S. pyogenes. It occurs as a result of minor scratches and abrasions and insect bites. So think of it this way. You're a kid, and you're playing outside, and it's summertime, because that's what kids do in the summertime, hopefully. Now, when I was a kid, come around 6, 7 o'clock at night, my mom would start flashing that porch light. And so help me God, if I did not see that porch light flash, I better be in. Then I'd get inside, and I'm a kid, so maybe I didn't wash my hands that good, and you begin to scratch all those little mosquito bites that you got while you were outside. Well, as you scratch, you're going to introduce group A strep from your skin into your open wound on, say, your arm. So you scratch, you scratch, you scratch, and then in doing so, you're putting the bacteria into your arm. This is a pretty common course. And what happens is you wind up with these weepy erythematous lesions on the skin, as shown here. They're sometimes referred to as honey-crusted, and you can generally differentiate them from a staph skin infection just by appearance. Staph infections typically have this bullae form, where you're seeing these like blisters, whereas with streptococcal impetigo, you're going to see these honey-crusted lesions. Okay, we're going to handle the next two diseases that strep pyogenes can cause together. We're going to start with cellulitis, but really we're talking about both cellulitis and erysipelas because we're going to talk about how you tell the two apart, okay? So these conditions manifest as an area of skin that's erythematous, it's got edema and warmth, and they develop as a result of the bacterial entry via breaches in the skin barrier, not that different from impetigo. Both cellulitis and erysipelas are almost always unilateral, so you're only going to see them on one side of the body, not both. And they typically involve the lower extremities, but as you can see here, that's not always true. Sometimes we'll see something like periorbital cellulitis. Both cellulitis and erysipelas can include things like lymphangitis, which you can see here. So if you look at this patient, you can see this red striping going up the patient's leg, and that's just indicative of basically inflammation of the blood vessels as the organism tracks its way up the leg. And they can also lead to inflammation of the regional lymph nodes or the lymphatics. So what's the difference? So with cellulitis, it usually involves the deeper dermis as well as the subcutaneous fat. So we're talking about a kind of a different location here. Cellulitis might present with or without purulence. You may or may not have pus. And then the other thing that you're going to want to keep in mind when we're talking about cellulitis is that sometimes patients tend to have a more indolent course. So they don't necessarily get systemic symptoms right away. They can have kind of localized symptoms and swelling over a few days before you get onset of manifestations of systemic symptoms like fever. And the other thing is that the margins of the involved or uninvolved skin are not always clear. So in this case, it's pretty clear. This tissue is involved, this one isn't. But if you look at this patient down here, we can't really be sure where the margin is of what's involved and what's not. And same with this little boy over here with the periorbital cellulitis. We can see that he's got some swelling here, but we can't be certain necessarily where the margins of the involved tissue and uninvolved tissue are. With erysipelas, the margins are a little bit more clear, as you can see here in this photo that I got from the CDC. So with erysipelas, we're really talking about the upper dermis. So remember with cellulitis, we were talking about the deeper dermis. So with erysipelas, it's your upper dermis and kind of the superficial lymphatics. Erysipelas is non-purulent. You're not going to see pus typically when we talk about erysipelas. Patients in this case, though, tend to have a more acute onset of symptoms with systemic manifestations, including fever and chills, occurring typically at about the same time of their rash. Typically, there's a very clear demarcation between the uninvolved and the involved skin, as you can see here. So in this case, the doctor actually drew this dotted line on the patient because cellulitis can be very quick moving and you want to see if it's going to move very quickly. So you'll draw this line and you'll wait for 10-15 minutes and see if the redness actually tracks past that line up the skin. And you can do that with erysipelas. We used to see erysipelas a lot on the face, and in that case it was associated with maybe a previous pharyngeal infection, but often these days we see it in the lower extremities. So here's where cellulitis can get really bad, and that's necrotizing fasciitis, or the flesh-eating bacteria. And if that sounds scary, it's because it kind of is. Thankfully, it doesn't happen very often. Sometimes this is also referred to as hospital gangrene. This occurs deep in the sub-Q tissue, so we're getting the organism really deep in there. And what it's going to do is it's going to spread along the fascial planes, And it's characterized by basically extensive destruction of the muscle and the fat, as you can see here. What happens is that S. pyogenes is introduced into the tissue through a break in the skin, either by a minor cut or trauma or vesicular wall infection, burn patients, surgical patients. So for example, this patient had a compound fracture. And then you can see, if you look really close here, there are these 3 purple dots. Those are actually some lesions, some small bullae that are forming. And you can see some of the cellulitis that's starting here, kind of the redness here and here, but the skin over here and here is uninfected or unaffected. And within a couple of hours, the patient reported severe pain, systemic symptoms, and when they opened the leg up, they saw this severe invasion. You can see down here this dead tissue in black here as the organism ate its way through the limb. Unfortunately for this patient, despite rampant antibiotic treatment, they were not able to save the patient. So just like in this patient with necrotizing fasciitis, initially you're going to see evidence of cellulitis, and after which you're going to see some of these bullae form, gangrene and systemic symptoms develop. Eventually toxicity, multi-organ failure, and death are kind of the hallmarks of these diseases. The only way really to treat this is surgery and antibiotics, and that's pretty much what happened with this little guy. This is a amputated infant's arm where basically the patient had a group A strep infection of the arm, and the only way to save the baby's life was to amputate the arm and treat with antibiotics. But in this case, the baby did survive. And this is kind of also an example of how group A strep can move from cellulitis to necrotizing fasciitis, and eventually, in the case of this patient, to basically toxic shock. So you get a patient that's experiencing a soft tissue inflammation at the site of infection, pain, nonspecific symptoms such as fever, chills, malaise, nausea, vomiting, diarrhea. And then as the pain intensifies, that's evidence of the disease progressing to shock and eventually failure of the kidneys, lungs, liver, and or heart. Basically features very similar to staphylococcal toxic shock syndrome. Most patients with streptococcal toxic shock syndrome are bacteremic, and many of them will have necrotizing fasciitis. There, as I mentioned before, are 2 post-infectious sequelae of group A strep that you have to know. The first one is rheumatic fever. If any of you read Little Women, my mother was obsessed with Little Women, insisted that we all read it. Beth went and babysat the Hummel children, and one of the children there had scarlet fever. And then Beth came down with pharyngitis and scarlet fever, and she got the ultimate bad luck because she also developed rheumatic fever. And that happened a lot in that day and age because we didn't have antibiotics. So rheumatic fever only occurs after pharyngitis, and it occurs 1 to 3 weeks after pharyngitis, but it can be prevented. It can be prevented by treating the patient with penicillin within those 1 to 3 weeks of their pharyngeal infection. So why is that important? Earlier I told you that you were going to culture all negative strep tests. So your patient comes in, they think they have, pharyngitis. You do the strep throat swab and it comes back negative. You still send it out for culture, and this is why. Because if they are within that 1 to 3 week window, even if they start to feel better, you can still treat them with penicillin and you can avoid rheumatic fever. And you'll see this occasionally in kids where parents will bring their kid in for a visit and they'll say, oh, little Johnny's been doing fine. He did have a sore throat about a week ago, but he cleared it. Now, if you were to do a strep throat test on that child, then it would definitely show up negative because the child cleared the infection. There's no organisms left to leave antigen to turn your rapid strep test positive. So what do you do instead to find out if that kid actually had strep throat? Well, that's where those ASO and ADB titers come in. A person like you or me who maybe has not had strep throat in a very long time will have a titer of ASO or ADB that's about 1 to 200. A person who has recently, like in the last week or so, had strep throat will have a titer of like 1 to 3,500. It'll be something pretty striking. So then when that ASO titer comes back positive, and little Johnny only had his pharyngitis about a week ago, you treat him with penicillin and you avoid basically giving him a damaged heart valve. Because remember, we make antibodies to M protein, and M protein is very similar to myosin, which is in our hearts. So you can wind up with these damaged mitral valves, is the most common, but other valves can also become problematic. So you have these weakened valves, and that's what happened to poor Beth in Little Women. She had a weak heart from then on. The criterion for diagnosing rheumatic fever after the fact, if you didn't catch it during this window, are pretty clear. You're going to identify joint pain. Like I said, you'll have the damaged valves, so this is the Jones criterion, but the O is a heart. Isn't that cute? You'll also get these subcutaneous nodules. You can see them here. It's not uncommon to have this kind of watercolor rash that's called erythema marginatum. And then another one is a neurologic symptom, Sydenham's chorea, which is basically the involuntary movements of the hand and face that can show up in these patients. So preventing it is really simple. Just give them penicillin. You want to avoid rheumatic fever because it damages the heart, and patients who have damaged mitral valves basically have a high incidence of needing antibiotics to protect them from transient bacteremia that might further damage their hearts, like in the instance of like dental procedures. The other thing that can occasionally happen with post-infectious sequelae of group A strep is this acute post-streptococcal glomerulonephritis. This one can occur either after something like impetigo or pharyngitis, whereas rheumatic fever only occurs after pharyngitis. In this case, symptoms include hematuria, edema, and hypertension. So basically, it's a renal effect. This is actually a type 3 hypersensitivity. Basically means that we're making antibodies and antibody-antigen complexes, and then they're depositing in spaces where blood is often filtered, like our kidneys. And when antibodies get deposited in our kidneys, it leads to inflammation of the kidney. On the plus side, this is typically a self-limited situation. It can be a little severe while it's going on, but we can provide supportive care. On the bad side, we can't really avoid it like we could with rheumatic fever. Penicillin treatment won't prevent this one. So what do we do for group A strep in general? You've heard me say penicillin a couple times. Penicillin or amoxicillin are completely acceptable treatments currently for group A strep. And that'll be good for pharyngitis, scarlet fever, sinusitis. It can cause some of those, impetigo, erysipelas, some of your more run-of-the-mill infections. If you have something really severe like a cellulitis or a necrotizing fasciitis or, God forbid, sepsis, ceftriaxone, vancomycin are some options. Don't forget that with necrotizing fasciitis, you must always treat with surgical debridement. You're literally cutting away the infected tissue, and it's a really important point for standard of care. So those are all of the diseases that are caused by group A streptococcus.